Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Welcome to Dialogue with the Doctor, or welcome back to Dialogue with the Doctor, and we are welcoming back Dr. Raymond Phillips, Ray Phillips. He's a practicing board-certified gastroenterologist here in Naples. We're going to be talking about hepatitis C tonight, which many people are very confused about. But we first want to ask Dr. Phillips about himself briefly before we get started.
Hey Greg, thanks a lot for having me back. I always enjoy returning and talking about these different subjects. And one of the things that's important to understand is that what is a gastroenterologist and what do we do and what kind of training do we have? Well, I'm a board certified gastroenterologist, and what that means is that we completed college. I went to Princeton University, went to medical school at Washington University in St. Louis, graduated there, and then went on to do my internal medicine training and residency at Jefferson Hospital in Philadelphia, and I was chief resident there for a 4th year. I went on active duty then because that's how I got through college, went through Princeton on an ROTC scholarship and went on active duty in the Army and practiced as an internist for 2 years, and then I was selected for gastroenterology training at Walter Reed for 2 years, and then I was on staff at Walter Reed where I supervised training as well as doing some research programs. So a gastroenterologist is an expert in digestive disease as well as liver disease and has a great deal of training, anywhere from 14 to 16 years of education. And so when you're speaking with a gastroenterologist, you're speaking to one who is an expert in those areas in terms of digestive ailments and liver disease as well as pancreatic disease as well as nutrition. And the topic we were discussing earlier about hepatitis C is one that's occupied our attention in terms of gastroenterologists and liver specialists for the last 30 years since it was discovered.
Well, patients are always confused about what hepatitis is. Why don't you tell us what hepatitis is?
Well, hepatitis in general just means inflammation of the liver. And there can be many, many things that can cause inflammation, all the way from a reaction to a medication to autoimmune illness. But in this context, viral hepatitis, there are a number of different viruses that can cause inflammation of the liver. And gastroenterologists, not being terribly imaginative, we've enumerated them, or rather lettered them, A, B, C, D, E, F, and G, and we're currently up to G right now. But the principal ones are A, B, and C. Hepatitis A is a viral hepatitis you get from eating shellfish, for example. There is a vaccine for it. Hepatitis B is from blood contact or close sexual contact. Very, very common in Asia and China, not so common in the United States. Hepatitis C is a virus that is transmitted as a consequence of blood contact, almost exclusively through blood contact. And as a consequence of a number of events, principally the Vietnam War and the importation of hepatitis C from Vietnam and the widespread use of IV drugs during that time and heroin addicts, it became very, very common in the 1970s and 80s across the United States. So it's now by itself, hepatitis C doesn't cause that many troubles. You may have an initial period of jaundice. Most people get better clinically. The troublesome thing is there's a significant number of people who have hepatitis C. About 80% will go on to a chronic illness, and they won't even be aware that they have it. And in that setting, after decades of this infection, it can lead to accumulation of injury to the liver, scarring that can lead to side effects or consequences where the liver becomes so badly damaged it can't function properly, or you get complications from the scar tissue itself, such as accumulation of fluid in the abdomen called ascites, or very, very large veins that develop in the esophagus called varices that can sometimes bleed spontaneously.
So of those 80% that go on to chronically have it, how many of those patients get injury to their liver?
And about a fifth, about 20%. About 20% of those will get a cirrhosis and all the complications we mentioned. So in the United States, about 3 or 4 million people, say 4 million, about 20-25% of them will go on to develop cirrhosis and the complications thereof. And I mentioned the two principal ones fluid accumulation ascites, as well as bleeding from varices. But the others include liver failure, requiring a liver transplantation, or even the development of liver cancer. And so all of these things are major complications, but they're only apparent after a person has had a chronic infection for many, many years. And during that time of infection, the person may not necessarily have any symptoms at all.
So it has to be detected.
Yeah, it has to be detected. And the frustration with that is that we had means of detecting hepatitis C. It only became widespread in terms of a means of detecting it through blood testing in the late 1980s and 1990s. And before that, because we did not have means of screening for that, oftentimes individuals would have just mild elevation liver tests, and we would suspect they have a virus, wouldn't be certain. That was a time, however, when the blood bank or the banking industry in general, that is to say the, the Red Cross, they were very welcoming in terms of receiving transfusions at the time. And so, and since they didn't have any effective ways of screening for viruses, they pretty much, and it was in the days of paying for donors and so forth, you know, a lot of individuals who donated should not have donated, and as a consequence put recipients at risk and actually transfused hepatitis C in many people. As a result of that experience in the 1980s, the blood banking community has become very, very cautious now in terms of infectious agents in the blood collection process. And that's why we see in the advent of nationwide Zika testing and exclusion of individuals across the United States for Zika positive, even in parts of the United States that never had any detection of Zika at all. So it just shows a pendulum swing to the opposite extreme, where the blood banking community now has become very, very cautious about potentially transmitting an infectious agent.
They're erring on the side of safety. We're being told to screen anybody born between, is it 1950 and 1965? Is that what it is?
Well, sadly, you know, they're basically saying, hey, any baby boomer ought to be screened. That is to say, anyone born between 1945 and 1965 ought to be screened. Formerly, the CDC had this policy of trying to just screen high-risk individuals who were using IV drugs in the past and so forth, but found that wasn't a very effective strategy. So now, essentially, anyone who was born in that time frame that I've just mentioned to you, they really ought to be screened for hepatitis C. And what we're finding is with that screening process, we'll be able to detect 85 to 90% of individuals who have hepatitis C. And you might say, well, who cares, you know, if you don't have effective therapy? But, you know, the exciting thing is now we do have effective therapy that has become available in the last 2 years. And it's a new era, a new dawn for therapy of hepatitis C.
Well, prior to that, the therapy was very problematic, as I recall.
Well, it was excruciating. That is to say, yeah, in the early 90s, when the best therapy was interferon, and we only cured 1 person out of 20, and we were extraordinarily happy about that. And that was after a year's worth of therapy where an individual had basically a severe flu for a whole year. And that was the nature of interferon. It would rev up the immune system and create like flu-like symptoms. Over time, other agents were added to interferon, ribavirin, and that was never well received, ribavirin, as you can see. And then other agents, as we understood the replication process of hepatitis C and understood the different steps, we're able, and this is really slick, using molecular biology to be able to actually target different steps in the virus replication process. And with that, being able to know the actual proteins and being able to figure out how these proteins folded and be able to find particular agents that would fit in those niches, those folds, and prevent replication, we're able to really now, in the last 3 years, 4 years, develop agents that are very effective and target different steps of the process. So now we're at a stage where we can cure 99% of people.
99%?
99%.
You talked before about symptoms. You touched on symptoms because patients want to know, well, how will I know if I have it? I mean, how do people present with symptoms?
Well, and that's the trouble. When they initially have an infection, they might get jaundice, get a yellowness of their eyes and tiredness, but usually that phase of muscle aches, joint aches, tiredness, jaundice might last 6 weeks. And a young adult, it may not even be apparent at all. And after that resolves, as I said, about 80% of people will go on to a chronic infection, and you really won't have any symptoms at all. You might feel a little bit tired, but that's the only symptom that individuals with chronic hepatitis C will typically have. And with the widespread advent of biochemical testing in the context of physical examinations, yeah, we were noticing a number of individuals would have mild elevation of liver enzymes, and that's a clue that an individual might have chronic viral hepatitis and would prompt one to check for hepatitis C.
My patients are frequently confused by the testing, antibody testing versus viral load and these concepts. Can you tell us about that?
Sure. The testing is as I said, was first developed in 1989, 1990, and it was an antibody test. That is to say, every virus you get exposed to in your lifetime, your body, your immune system develops antibodies to it, and those antibodies remain in your body, remain for the rest of your life. And so the same with hepatitis C. Once you get exposed to hepatitis C, you develop antibodies. Unhappily, these antibodies are not effective for protecting you from this infection because the virus is able to mutate so rapidly. It mutates and changes its appearance, so it cannot be fully eliminated by your immune system. And so it's always one step ahead of your immune system in terms of mutating to a new form. And now, with the availability of advances in molecular biology, we're able to actually check for the virus itself now, rather than just the body's immune system response to the virus. We're able to actually measure the virus, how much of the virus, and now we've learned there's different varieties or breeds or genotypes of the hepatitis C. And these genotypes are 1 through 6. But now we have a means of actually measuring the virus, determining what breed it is or genotype it is. And those pieces of information now allow us a means of really knowing whether there's an active infection or not.
So some of the breeds are more injurious than others?
Hey, you're exactly right. The one that's most common in the United States, genotype 175%, is one that is typically is not associated with cirrhosis so much. Genotype 2 and 3 are more likely to cause cirrhosis or other issues. Genotype 4, 5, and 6 are rare in the United States, more common in Egypt and Asia than in the United States. So 1, 2, and 3 are the ones that get most of our attention. And it used to be particularly genotypes were susceptible to therapy, and since genotype 1 was the most common, most of the initial therapies in the last couple of years were directed toward that. But now we're coming out with therapies that are effective for all varieties of hepatitis C, and no longer just targeted for genotype 1 or 2, but is effective for all varieties of hepatitis C.
So I can recall when we were doing typing and we'd get a typing result 2, 2B, that was important because it would decide the treatment. That's not as important anymore?
That's not as relevant as it once was. And in the next year or so, it really won't matter that much at all, because with now, we call them pan-genotypic therapies. The first has just been developed, but other ones are coming out. With these therapies that are effective, 98, 99% effective against all varieties of hepatitis C, it doesn't really matter so much what varieties it is. What is relevant, though, is how much damage has accrued in the liver, because if there is scarring like cirrhosis, you may need a supplemental therapy with a drug called ribavirin in addition to these newer agents.
Well, we want to thank Dr. Phillips for being here with us talking about hepatitis C. And we really appreciate what he's told us, and we expect him to come back another time soon.